Tonight we're okay.
Sweet recording. All right.
I just know that we're recording. Sue remembered. She set her alarm. I'm so proud of her.
Yay.
At any rate, I want to thank Sue for putting this all together and figuring out how we could do this so that hopefully you can see it. I would be surprised if there aren't glitches along the way. And if there are, if you put them in chat, or you can call me on my cell phone at 435-640-0342. Toph knows that, so he'll see the glitches. Tonight, we are really lucky that Mary is going to give us the second update that she did. She did the same lecture last year, and it's almost hard to believe how much has changed since we were doing this last year, let alone how amazingly much has changed since COVID started. But it's such an important topic. It affects us every single day with everything we do. I recently, did a little crazy thing yesterday, and I was up in an airplane, and whenever I'm up in an airplane, especially this is a military jet, I was worried that I was going to crash, so I had to think about my life, and I realized that this last year has been about as crazy as any year of my life, and I grew up in the 60s, so I had a pretty crazy life. But at any rate, Mary's going to talk to us, and let me tell you about Mary. Mary is, as you can see there, she's a physician's assistant who works for us, and she works at both our Instacare and at the Round Valley facility. She is about as awesome a provider as I know, and I can say that both from watching her and also because she's kind enough to try and keep me out of trouble medically and takes care of me. And I could go on and tell you about all the things that she does in the community, or all the things she does with her family, or all the things she does as a human being, but that would take the whole hour. So instead, I'm just going to turn it over to her to let her talk about this. And again, what we'll do, if you have questions, either just unmute yourself and shout out, or easier is put them in chat, and Sue or I'll be watching it, and we will let Mary know at an appropriate time. There'll be time for questions at the end as well. So without further ado, take it away, Sue.
Or Mary.
Or Mary, either or.
Let's try this again. Let's try it again. I'm a little bit under the weather today. Let's take it away, Mary. So everything that, if I use Sue's name in vain instead of Mary,
it's totally understandable. Don't worry. Oh my gosh. It's all good.
I also have to tell you that Sue, and Sue also keeps me out of trouble and is a head nurse, and we work all the time. So you could almost say a mirror image that Sue's performance at work is only matched by her performance as a human being. So I am lucky to be surrounded by the most awesome women that I can imagine if I add my wife to that. So without further ado, take it away, Mary.
Hey, so that was very kind, Woody. Thank you for the nice intro. That was way too kind. He's totally like, yeah, I'm like, if I'm a quarter of that, that'd be awesome. So, well, let's get started, you guys. So I kind of have a long presentation. And like you said, if you have questions, you can put it in chat, and I'll try my best to answer them. I don't have answers to everything, but there's a lot of unknowns, but we know a little bit more since COVID started. So hopefully we can begin with that. So first off, I have no conflicts of interest. And we can go ahead and get started. So we talked about some of this last year, so some of this is review, but if you're a new patroller, this will all may be new to you. So the origins of COVID-19 and definition. Near the end of the year in 2019, there was a novel or new coronavirus that was identified as a cluster, the cause of a cluster of pneumonias in Wuhan, China. COVID-19, when we say that, that's the disease caused by SARS-CoV-2. And the way they came up with COVID, CO for corona, VI for virus, and D for disease. And then 19 comes from, it was noted in the year 2019. It's not because it's the 19th SARS-like illness. And then SARS-CoV-2 is the virus that causes COVID-19. SARS-CoV-2 stands for severe acute respiratory syndrome coronavirus. 2, it was named in February 2020, and the name was chosen because its similarity to the SARS virus in 2003. So that's how they came up with that name. The global impact, it's funny, so had this lecture last year when we, at this point in time, and this is really tragic. We've had 246 million confirmed cases for the worldwide, including almost 5 million deaths worldwide as well as of yesterday. In the United States, we have 46 million cases and 739 deaths. In Utah, we've had around 500,000 cases and 3,000 deaths, and COVID was the third leading cause of death in 2020. So it is significant. It's not just a cold. Transmission of SARS-CoV-2, mainly it's person to person primary mode of transmission there. So you might get those type of things. Transmission of COVID, this is important. We really think it's more, there's a droplet component and there's also an airborne component that I think we're now saying, and like, this probably is a little bit more airborne than we initially thought it was. But mainly that it's droplet, meaning that it comes in, you'll get this in close range with contacts when you're approximately 6 feet apart or less apart, and you can get it when a person talks, sneezes, coughs, sings. And the virus can infect another person if it's inhaled or makes direct contact with your mucous membranes. So that would be like, in eyes, nose, mouth. The infection also might occur if the person's hands are contaminated by droplets or touching a contaminated surface, and then you immediately touch, any of your mucous membranes. Although contaminated surfaces are not thought to be a major route of transmission. Now they're saying, with COVID, SARS-CoV-2, it can also be transmitted longer distances through airborne route. So this is anything more than 6 feet, which is through inhalation particles smaller than droplets that remain in the air over time and distance. But the extent of which this mode of transmission has contributed to the pandemic is probably much lower. However, where there's areas with poor ventilation, it's an ideal environment for airborne transmission. So that's why we've kind of made such a big hubbub about like opening up windows if you can, be outside, get better ventilation, because there may be this component to it as well. Viral shedding. So this is, when you're shedding your virus, the duration of viral shedding varies significantly and depends on severity of your illness. Potential to transmit SARS-CoV-2 begins prior to the development of symptoms and is the highest early in the course of the illness. And the risk of transmission, greatest infectious disease, so you're still saying it's 3 days before symptoms start and up to 7 days after symptoms start. Transmission after 10 days is pretty rare. However, if someone has a severe illness or is even possibly immunocompromised, the shedding can occur up to even 20 days. So if you have a really poor immune system and you're not fighting this virus, you still can potentially shed this virus. The other little caveat is too, sometimes when you're doing some of these PCR swabs and you get a positive RNA detection of a SARS-CoV-2 for months afterwards, sometimes for some folks, that not necessarily means viral shedding of a virus that is competent to replicate, meaning that you can still test positive. Some people will, and you'll get that like, a couple of weeks later where I've had patients come in, I'm still positive. Well, they're probably not shedding a competent virus at that point in time. And we say, as long as they're asymptomatic and they've had the 10-day quarantine, you're probably off the hook at that point. Transmission, the risk of transmission after contact with individuals with COVID-19 increases with closeness and duration of contact and appears highest with prolonged contact in indoor settings. You can see on the graph things that increase risk. There's like no mask worn, being in indoors and being crowded. That's going to cause, probably an outbreak. Things that decrease risk are wearing masks, 6 feet of space between people, and being outdoors. That's more like white, because obviously, masks aren't perfect. And sometimes, like I said, if it's airborne and you're in a poor ventilated space, there's still that potential. Environmental contamination. So you're thinking about like, all these people on a chairlift touching the bar, or all these like hot, contact points. It's possible that contaminated surfaces can be the source of infection if the person touches their mucous membranes in their mouth, eyes, or nose. There are many unknowns, and scientists think that this mode of transmission is less likely. However, areas with heavy viral contamination also may play a more potential source. It is unknown how long it can persist on surfaces, but we believe the coronavirus has been tested and may survive on inanimate surfaces for up to 6 to 9 days without disinfection. Disinfection though, so if you use like your alcohol wiper, disinfectant spray, or like a Lysol spray, it can kill the virus in less than a minute. And the good news is that you guys work mostly outside. So 20 minutes of sunlight has been shown in some studies to deactivate the virus. So that's really helpful. So as long as it's a sunny day. And then animal contact. So here's all your patrol dogs and all their handlers. So some old pictures. With likely human to human and very rare, but very unlikely to cause continued transmission of SARS-CoV-2. No cases of domestic animals transmitting the virus to humans, but the CDC recommends quarantining from your animal if you're sick. Just on a side note, I thought this was interesting as I was like going through the news. I guess our lions down at the Hogle Zoo all have COVID. So I guess 4 of their 5 have the Delta variant, which is interesting. So they're exhibiting symptoms of coughing and sneezing. So our African lions are there. So just be careful if you go to the COVID Zoo or the Hogle Zoo. So they're monitoring that situation. And then here's the spectrum of disease for COVID. You have people who are asymptomatic, have no symptoms with this, and are walking around spreading it and, hugging people and, so they're feeling fine. And then there's people who are mild, and mild is just literally anyone who hasn't needed to be hospitalized. And then there's severe. So that's people who are hospitalized or are at risk of death. So asymptomatic, like I said, is positive COVID, but no symptoms. They believe that about 30 to 40% of all COVID cases can be asymptomatic. And then quick, side note, if you are asymptomatic, so say you're around some people and you're asymptomatic, you have no symptoms, but you tested positive, you still have to quarantine. You still have to, for 10 days, so you still have to do the quarantine. And, if you had a positive COVID-19 test. Mild COVID is basically any course that does not develop. It's approximately 80% of cases. Severe critical COVID cases are severe disease, which is described as a case of dyspnea, hypoxia, or 50% of lung involvement on imaging. This is about 14% of cases, and critical disease is described as a case with respiratory failure, shock, or multi-organ dysfunction. So with that, and those critical ones are about 4% of cases. Risk factors for severe or greater illness. So you can see, as we all kind of know at this point in time, if you, have any chronic medical conditions, more or less, will put you at higher risk. So this includes obesity. So anyone with a BMI over 25, having diabetes type 1 or 2, high blood pressure, which is really common, having any chronic lung disease, including asthma or COPD, cancer, having coronary artery disease, congestive heart failure, having chronic kidney disease, neurological conditions like dementia or stroke, Down syndrome, being immunosuppressed, like being on having HIV or some disease that suppresses your immune system, or taking immunosuppressive medication, like people who may do for autoimmune diseases. Having sickle cell, pregnancy is also high risk, smoking is high risk, having a history of solid organ transplant or bone marrow transplant. Also your race, if you're non-white race, is likely, and that is mostly likely due to disparities in healthcare. But that is a risk factor. Also being older than 65, because 80% of deaths from COVID-19 are over 65. And basically if you're over 45, that's 95% of death disorder. It can also be risk factors. Mortality rate, it's around 2.3 worldwide. Most of the fatal cases occurred in all patients with advanced age or underlying medical comorbidities, but it can be fatal in all ages. So all ages has had fatalities from this disease. And mortality rates varies by location and time. When we first initially didn't know how to treat this or do correct therapeutics. Like when it was going around in Wuhan, the mortality rate was 5.7. The rest of China, after a while, after you learned how to, give monoclonal antibodies or different, steroids, it was 0.7. In Italy, when they had that outbreak in Northern Italy, the rate was 7.2. And like I said, currently in the United States, it's around 2 to 3%. Since many SARS-CoV-2 infections are asymptomatic, the infection fatality rate is considerably lower and has by some analysis likely between 0.5 and 1%. Conversely, the reported case fatality rates are likely underestimates of the true case fatality rates, as many fatal infections may be undiagnosed. I just thought this was really funny. She basically says, this pandemic is the worst group project I've been on, I've been a part of in my life. I agree. This pandemic has been interesting. Everyone has a different opinion on how we're going to solve this, and whether it's an informed decision. I believe that was so true. I'm like, I hate group projects, and the pandemic is definitely the worst group project I think we've all ever been on. Clinical manifestations of COVID. So we'll talk about incubation, initial symptoms, clinical course and recovery, and also long haul symptoms. So incubation of COVID. So basically what incubation means is the period of time between getting infected with the germs and then the appearance of symptoms of the illness or disease. Incubation can be up to 14 days, but it's usually 5 to 7 days. So you can see this calendar. So the days are exposed. The first red dot square there is the days you're exposed to the virus. And then, days you actually start having symptoms, that's your incubation period. Symptoms of COVID, like we said, there's no real specific signs or symptoms that can reliably distinguish COVID. We used to just say, oh, if you've lost your sense or smell, like initially it was like, that was COVID, and that's, you had to have that to have COVID. Or if you had a sore throat, that wasn't COVID. That's not true with COVID-19, especially if you develop dyspnea or shortness of breath approximately a week after having the initial symptoms is highly suggestive of COVID. But symptoms can be, cough, fever, myalgias, which is body aches, headache, dyspnea, shortness of breath, sore throat. And then with this Delta variant, we're definitely seeing a lot more GI symptoms like diarrhea, nausea, vomiting. And sometimes those are the only symptoms we'll see at the clinic. And then you can still see the loss of taste and smell, abdominal pain, and rhinorrhea or runny nose. The clinical course of COVID, some patients with initially non-severe symptoms may progress over the course of 7 days. They usually progressively get dyspnea. Then some things that can happen further down the course is you can get respiratory failure, or acute respiratory distress symptom is the major complication in patients with severe disease. It can present shortly after the onset of dyspnea. Cardiac or cardiovascular complications, including like arrhythmias, cardiac injury or shock, and then also having things like blood clots, so thromboembolic complications like a pulmonary embolism or acute stroke. Despite not having any other risk factors. So unfortunately, I think this community, we saw a young person in their early 20s with that happen. They had COVID, and then a week later had a major PE that was fatal, and had pretty much no other symptoms with their COVID. And then you can also have inflammatory complications. Some patients with COVID-19 have evidence, laboratory evidence of exuberant inflammatory response, similar to a cytokine release syndrome, where they get these persistent fevers, elevated inflammatory markers like the D-dimer or ferritin, elevated pro-inflammatory cytokinins, and these laboratory abnormalities have been associated with critical or fatal illness. So it's like your body has this huge inflammatory response, and that can also be actually very harmful with that. And then recovery and long-term sequelae of COVID-19. Mild infections, it's usually 2 weeks you can recover, but some do have longer persistent symptoms like cough and fatigue. Severe critical course, it's extremely variable. Some people get out of the ICU and walk out of there, and some people get wheeled into a long-term care facility because their lungs are completely trashed, or their heart's been trashed from COVID, or they have severe cognitive issues after COVID. So it's extremely variable. But the most common persistent symptom with those with the severe disease was fatigue, dyspnea, joint pain, and chest pain. And we talked briefly about long COVID. You've probably heard this in the news and may have known somebody or personally had this if you've had COVID. So these usually COVID, mild COVID or moderate COVID lasts for about 2 weeks for most people, but some people experience lingering health problems even when they have recovered from their acute phase of illness. According to the CDC, the most common long COVID symptoms are fatigue, shortness of breath, cough, joint pain, and chest pain. Other issues include cognitive problems like brain fog, difficulty concentrating, depression, muscle pain, headache, rapid heartbeat, and intermittent fever. I could definitely say in my practice, I've had, some patients who have had this. The best we can do for these people is send them to our long COVID clinic at the University of Utah that we currently have. And they kind of have a multidisciplinary approach for long COVID, but there's no magic cure to make their brain fog go away or to make their fatigue go away. Sometimes it's just time for it to go away. And then I'll just show you guys, since you guys are medical and probably interested in some of the imaging. So this is just a mild disease. Chest X-ray may be normal, or you can have consolidation and ground glass opacity. So you can kind of see that ground glass opacities and a little bit of consolidation there on the chest X-ray on that. The CT is pretty apparent. If you look on the right side of the CT, your right, not the patient's right, the CT, you can see all that looks like your ground glass opacities without consolidative abnormalities. So you'll see these CTs that look pretty terrible, and they can last. I had patient CT that looks like this, looked like that 6 months after she was out of the hospital. It's pretty yucky. And then, like I said, here's the imperfect toolkit for fighting COVID. I wish vaccines were, 100% and people didn't catch them, catch COVID from it. But vaccines that we have, especially that we have now, are awesome. I mean, they keep you out of the hospital, they keep you from severe disease. And so we have that. Masks, they're great. They're not perfect though either. But if used correctly, they do help social distancing. So not like going to a huge crowded indoor place without masks, and then better treatments as well. So prevention of, we talked about this quickly, social distancing, 6 feet from one another, wearing masks indoors, eye protection when in close contact, washing your hands frequently, avoiding touching mucous membranes like eyes, nose, and mouth, frequently cleaning and disinfecting high touch areas like doorknobs. Those often get really forgotten. If you guys are staying, inside the patrol shack, we're doing that. It should be wiped down several times a day, especially all the areas you guys touch. And try to leave the windows open if you can. Ensure there's adequate ventilation of indoor areas. And then, if people get symptoms or have anything, you're quarantining and isolating when needed. And then let's talk about masks really quickly, because we still, especially you guys in healthcare, still need to wear these. Like I said, they're not perfect, but studies show that they reinforce that the use of masks by both a potential transmitter and an exposed person. So both people need to wear them. The person who's maybe, has COVID and the person who doesn't have any symptoms both need to wear masks. And it substantially reduces the probability of successful transmission, even if a mask only lowers the exposed viral load by 50%. If people wear masks, it's found that the reproductive number would be below 1. There are models that predict that moderately efficacious masks will lower the exposure viral load tenfold among people who get infected despite masking, potentially limiting infection severity. So communities should wear, so what we recommend is like the community should wear non-medical masks. Since we're kind of in different times now where we do have more medical masks available to us, like there's, I think you find them on Amazon, but February 2020, you couldn't find medical masks. But community is okay if you're going to the grocery store with a non-medical mask. But those in high risk groups that we talked about, who have high blood pressure, over 65, they should wear a medical mask. And those who have symptoms consistent with COVID-19 should wear a medical mask. Mask should not have an exhalation valve on it. So the exhalation valve will just allow you just to spray virus out. It doesn't help anybody, as far as that you might be trying to help. So no exhalation valves. And cloth mask shouldn't just be one layer. It shouldn't be just like a neck gaiter. It needs to have several layers of fabric if you want to wear a cloth mask. These are masks. These are our medical masks. So you have a KN95. I like the KN95s because they keep the, they're not touching your lips or anything. So I drew a lot, unfortunately. So my mask doesn't get as wet. It stays, I like that. I actually try to use that for my kids as well because they chew their mask, which defeats the total purpose of it. So KN95 will stick out a little bit further. And an N95, I would especially wear this if you're in a situation where someone's getting nebulized or someone's coughing and you're walking into a situation where someone's really sick, or a surgical mask. So you guys should all carry, at least one of these in your pocket, and then maybe, at least the KN95 or N95 you should have with you as well, for any situations. And hope I'm doing okay on time. So masks, like I said, a good mask should have a double super layer of fabric. Should be washable. You should wash it, and breathable fabric that should help the wearer from potentially spreading it. A bandana tied around the face, like I said, doesn't work. A neck gaiter is not really good either. It's usually too thin. And like I said, for you guys, you should be doing a KN95 or N95 if you're doing, anything medical with someone, especially inside. And at this time, we build the level of vaccination nationwide. We must also use all these prevention strategies available, including masking indoors and in public places, to stop the transmission and stop the pandemic. So, even if you are vaccinated, there's still the CDC is still recommending that if you're inside, you wear a mask at this point. Everyone who is able, including fully vaccinated people, should wear a mask indoors in areas of substantial or high transmission areas. And then eye protection, your ski goggles are totally fine for eye protection. You actually probably saw videos of people like at ICUs wearing ski goggles, so they're fine. Or you can use a face shield like that if you need to. And then let's talk about vaccinations because, that's the new thing we didn't get to talk about last year. So all I could say was like, oh, we have mRNA in the works, but that's it. So we currently have right now, we have two mRNAs. So we have Pfizer, Moderna, and then the viral vector, which is your Johnson & Johnson. Work began in January deciphering the genome for SARS-CoV-2, and the first vaccine safety trials were started in March 2020. So they got right on that. So, and then 57% of all Americans are fully vaccinated according to the CDC. And basically 68% of the share of all the Americans 18 and older are fully vaccinated. At least 201 countries have started vaccinating against COVID-19, and 48% of the world's population has received at least one dose. 6.92 billion doses have been administered globally. That's a lot of doses. And 42 million are now administered each day. Only 3.1% of people in low-income countries have received at least one dose. So we're lucky. We're working on boosters right now. We live in a very wealthy country, so we're lucky, and it is sad that other countries don't even have access to one. So you gotta look sometimes like, gosh, I can't believe people aren't using doing these. But, and if you have people who are like, oh, I just want to wait and see, if you have family members or friends who are saying, oh, I just want to wait and see, make sure they're safe. Well, almost 7 billion have been administered globally. So I think now is the time, if you're waiting, to probably do it. Vaccines available in the United States. Like I said, we have Moderna. It's for anyone 18 years and older. Number of shots is 2 shots, 28 days apart. Pfizer is anyone 12 years and older, but probably by next week, it's going to be 5 years and older. I'm excited about that because I have a 6-year-old. So I'm hoping that's going to happen. And number of shots, it's like I said, it's still 2 shots, but this one is 21 days apart. So 3 weeks apart for Pfizer. Don't panic if you, for some reason, can't get your shot right at that 3-week mark. It's just, you have to adhere to at least the shortest interval. So you can't go earlier than 3 weeks, or you can't go earlier than 4 weeks with Moderna, but try to stick with the schedule. Johnson & Johnson uses a disabled adenovirus to deliver the instructions. The adenovirus is in no way related to coronavirus. It's completely different virus. Although it can deliver the instructions of how to defeat the coronavirus, it can't replicate in your body. It will not give you a viral infection. And Johnson & Johnson's authorized for anyone 18 years and older. Number of shots is 1, but I put a big asterisk on it because as of 7 days ago, the FDA authorized a single dose of the Johnson & Johnson vaccine Vaccine administered at least 2 months after completion of a single dose primary regimen to individuals 18 years of age and older. And also the FDA authorized use of a booster dose that's currently available for COVID-19 vaccines. So basically, the Johnson & Johnson recipients that are 18 years and older, they may receive a single booster dose of Johnson & Johnson, Moderna, or Pfizer vaccine at least 2 months from after receiving their first one. What I am doing with my patients who have received Johnson & Johnson, I'm recommending that they get one of our mRNA vaccines as their booster. So they're getting either a Pfizer or Moderna. That's currently our recommendation. Quick, we can go over, are vaccines safe? Yes. So like I said, 360 million COVID vaccines have been given in the United States as of from December to July. So those are kind of shortened what I said before, but and they're safe and effective. They're evaluated in tens of thousands of participants in clinical trials, and they also met all the FDA's rigorous scientific standards, basically for safety and effectiveness and manufacturing quality needed to support the use of emergency use authorization. COVID-19 vaccines do not give you COVID. So if you get the vaccine, you cannot get COVID from these, but you're going to get a sore arm. You might get a fever. You might have a pretty good, robust immune response. And that's normal. If you've already had COVID-19, do you need to get vaccinated? I get this question a lot in clinic. And we do recommend, you still get vaccinated. It's unclear how long you're protected from the disease after a previous infection. New research suggests that COVID-19 vaccines offer a better protection than natural immunity and can help prevent reinfection. A study published on August 13 by the CDC found that the unvaccinated individuals who have already had COVID-19 were more than twice as likely than fully vaccinated people to get COVID-19 again. And the research in the Lancet suggests that older adults are more likely to be reinfected with COVID-19 than younger population. And that difference can likely be explained by the natural changes that weaken the immune system as you age, the authors note. If you've had COVID-19 and were treated with any of the monoclonal antibodies or convalescent plasma, you should wait 90 days before getting the vaccine. So you do need to wait for that. So if you were hospitalized, you likely had one of those. So you should wait 90 days. COVID-19 vaccines are safe, even though they were developed quickly. They didn't skip any steps, in making this vaccine. And COVID vaccines may protect you more than one strand of virus. So viruses change and they mutate, like the Delta variant. Currently, our vaccines are good for the variants out there. So we're doing, they're good in that direction. And COVID-19 vaccines don't change your DNA. So they're mRNA vaccines that don't interact with your own DNA at all. So they trigger an immune response that creates antibodies to protect you from getting COVID-19. Vaccines in adults. So unvaccinated adults are 6 times more likely to test positive for COVID-19 and 11 times more likely to die from it in August 2021. So in that little graph there, the black's unvaccinated, blue is vaccinated. I mean, it's, pretty apparent if you're not vaccinated. And it's not if you get it, but when you're going to get COVID. Like if you're unvaccinated, it's kind of scary. Vaccine boosters. So there's a lot of questions. You guys are probably, if you guys got vaccinated last winter or spring, you guys are probably up for some boosters. And technically you guys are in the healthcare setting, so you deal with patients. So you guys are in a high risk setting. Okay. So these boosters are pertinent to you. Individuals who received, Pfizer or Moderna, they do recommend a booster shot at 6 months after your initial series. And also basically for people in high risk settings, so it's like healthcare or people who are teachers or who are around the public, like for, essential employees, anyone who's 18 who has underlying medical conditions. So any of those initial like high risk medical conditions like high blood pressure, substance abuse, diabetes, immunosuppressed, people who live in long-term, care facilities like, group home, or anyone who's 65 and older, recommending boosters. People who got the Johnson & Johnson vaccine booster shots, like we talked about, are recommended at 2 months from getting your last Johnson & Johnson. And there's, like I said, there's booster recommendations for all 3 of the vaccines. Eligible individuals may choose the vaccine they received a booster or which booster dose. So you can basically mix and match your booster shots. So you're okay to do that at this point in time. We originally were like, if you got Moderna, your second shot 4 weeks later is going to be Moderna. As of now, your booster shot, you can mix and match. So, all right. And then, like I said, we talked about the underlying conditions that would also, if you're, say, a 50-year-old, if you had any of these things, they recommend a booster shot with these. COVID-19 vaccines in children, probably not a whole bunch of you guys have children, but probably some of you guys have kids. There's a lot of controversy like, kids do relatively well with COVID. It's not, really, the mortality rate on children isn't really high, and it isn't, but they can develop a condition called multi-system inflammatory syndrome, or MISC, as well as inflammation of the heart muscle. Currently, as of today, 5,000 children have gotten that, the multi-inflammatory syndrome. And the 1.9 million cases that are reported among children ages 5 through 11, with approximately 8,300 children hospitalized to date, according to the CDC. That's a lot of kids being hospitalized for this. About 1/3 of these hospitalized children require treatment in the ICU, and the rate of hospitalization is 3 times higher among children of color than of white children. And serious effects of infection, including long COVID, hospitalizations, and death, are less frequent among children than among adults. But there are significant numbers of serious illness in young children warrant concern. Like I said, people that are 65 and older, this is more deadly, but kids end up in the ICU, and it's tragic. I personally know 3 kids that have ended up in the ICU with this, and it was awful. They were there for about 3 weeks. And it's awful, as a parent, you don't ever want your kid to go through that. Of the 73 million children in the US, fewer than 700 have died during the course of the pandemic. And I hate the way I worded that, because any death of a child is awful and tragic. That's terrible. But that's meaningful. I mean, that's somewhere in the region of 600 kids have died from it. Like, that's terrible. That shouldn't have happened. So vaccines in children, so they're showing off their Halloween costumes that they're going to wear in a couple of days. But so the FDA panel has recommended Pfizer vaccines for ages 5 through 11 as of October 26th. So hopefully we'll have a time frame by next week when they can get vaccinated. So my 6-year-old can get vaccinated. My other one, who's 4, who's bigger than his sister, still can't yet. But the vaccine's safe and 90% effective in preventing COVID-19 infections in this age group. And they're hoping that with kids getting vaccinated, for every million kids vaccinated, it'll prevent 50,000 infections, 250 hospitalizations. So they're hoping that's the prevention. And the dose of Pfizer for kids contains 1/3 of the amount of the active ingredient compared to the adult dose. So the adult dose is micrograms, so the kids is going to be like 10 micrograms. And you would still receive a second dose in 21 days after their first shot. So than that. But myocarditis in kids, it's resolvable when they get the vaccine with that. So quarantine, quick, I should have put this earlier in our slides, but quarantine, so what's the difference? Quarantine is someone who's might have been exposed, and isolation is just someone who was actually infected. So you don't need to quarantine after contact unless you have symptoms. However, we are still recommending that people get tested about 5 to 7 days after their exposure, even if they don't have any symptoms, and to still wear a mask indoors in public for 14 days following exposure until they test negative. And then isolation, like I said, this is if you actually have the disease and tested positive. So if you develop, COVID-19, we still want you to monitor your symptoms. If you have any emergency warning signs, like we said, trouble breathing, that's usually the biggest thing. Seek immediate care, go to the ER, stay in a separate bedroom from other household members, separate bathroom, separate, kitchen utensils, like don't cook food for your whole family if you're sick, and wear a mask when you're inside. And then this is our, who's really behind COVID, and it's Zoom because everything's on Zoom. So, and then variants, quickly talk about the most prominent one that we're worried right now is the Delta variant, since the summer, and basically causes more infections and spreads faster than other forms of SARS-CoV-2 and the virus that causes COVID-19. So data suggests that Delta variants might cause more severe illness than previous variants in unvaccinated people. 2 studies in Canada and Scotland, people infected with the Delta variant were more likely to be hospitalized than patients infected with the Alpha or original virus that caused COVID-19. And fully vaccinated people with Delta variant breakthrough infections can spread the virus to others. However, vaccinated people appear to spread the virus for a shorter time. And like I said, Delta is just way more contagious. And then there's one coming up around the corner called Delta Plus that they found in the UK. They think it's about 10% more contagious. But that's all they have on it so far. So we don't know a whole lot about it. There's a lot of speculation. So as this thing continues to mutate and rip through populations, we'll expect variants to continue to keep coming up. So, and then I think that's it. Yeah, that's it for the everything. So,
Well, Mary,
yeah,
I'm going to let you rest for a minute. I'm going to say a few words.
excellent.
Great job as always. You talk so fast and have so much to say. It's just great. It's just great. And as I think back, like I said, I'm a little under weather, so I'm not on a full cylinders today. But I forgot to tell all the patrollers that you started out as a ski patroller, and
I did.
I think that's important for them to know. And they all should know that Sue was a good enough skier that she's on the cover of magazine. That the picture I think is in our clinic. So they come to this lecture and all of our lectures with good experience that all of you patrollers have. I also failed to say hello to the new patrollers, and hope to get to meet you or at least talk to you. I think if you talk to the rest of your team, you'll find that that no question's too stupid, and I'm more than happy to try and answer all of your questions about COVID or pretty much anything else. So a couple questions that we got, but first, before I do that, I want to explain to you where we are, because I think having an overview has been real helpful for me, and I'm hoping it will help you. We have an infectious disease doctor who's also an epidemiologist, who's also a big time skier, and he ran a wilderness medicine program up in Washington, who's been kind enough to consult with all the time. And he's also, talked to Toph and several others and answered their questions. I talked to him, about a month ago, and he said, Winnie, I need to put into perspective where we are right now in this disease. He said, we are 2 different populations. There's the population of people who are vaccinated, and there's the population of people who are unvaccinated. And if you look at the people who are sick and the people who are dying, it's all the unvaccinated. And I can confirm that here in Utah, talking to people who work in the hospital, they find all the time that the hospitals are full, but it's all people who've been unvaccinated. And what it amounts to, if you look at any measure or any number, it's happening far greater to unvaccinated people. As Mary said, if you get COVID, you're 11 times more likely to die if you're unvaccinated than vaccinated. And then you have to go the step back to that. If you have been vaccinated, you are magnitudes less likely to get COVID. So what we're seeing is that we're seeing what happened in New York when this virus started, happening all over the country in small towns and rural America, where the hospitals are being overwhelmed, just like here, and it's all with unvaccinated people. And if you think about it, that not only affects the hospital workers who are risking their lives and their families' lives to take care of these people, but it also means that what happened to a friend of mine 3 days ago who had to go to the ER because she had a terrible infection and she sat on a gurney for 6 hours and didn't even get any treatment because there were no beds. And people with heart attacks, people who are in auto accidents, people who have all sorts of things are finding that they cannot get access to care because our hospitals are filled with COVID, people who are unvaccinated. So, I know all of us have different politics and think different things, but if you just look at the facts, we want people to be vaccinated because it helps them and it helps everyone else. And I think Mary went over the stats. I mean, for people to say it's not been around long enough or there hasn't been enough experience when there have been not only millions, but billions of people who have received these vaccines and, done just fine, that's ridiculous. And even the thing that Mary, I'm sure knows, but didn't mention, even though they developed the vaccine very, very quickly, that's because they were doing the research that allowed them to do the final steps for 10 years before this vaccine was developed. They were actually working on another vaccine and shift all the research over to COVID. And that's why we got so lucky to get a vaccine quickly and a good one. So that brings up all of you, except for the new people. I think all of you have had the booster of have had the initial series of Moderna. And one of the questions that I was asked by Max is, what should we get? Well, interestingly enough, you now have a choice. Prior to the choice, I would have said you definitely want to get the Moderna. And I have to tell you that that's the one I got. But our infectious disease person that I told you about, who follows the literature and knows of studies from all over the world, he says that he's pretty bullish on getting one of the other types. In other words, getting Pfizer if you've had Moderna, if that's the first one available. Fortunately, we're in a situation where both of them are available. My son signed up for a vaccine today, a booster, and he could have had either one. So it becomes a little bit trickier. And I have to say that, like I said, I got the Moderna because the only study that's been out that shows that mixing it might possibly, maybe give you a little bit better immunity. It's only one study and it was only a couple hundred people. So he's bullish on it because he saw the initial study, but he said, certainly no one should hesitate to get Moderna. But if it's, like I said, he's thinking about what he will recommend, but he needs more data for it and he wouldn't wait. So the long answer, to give you a very simple thing, I think you should all get Moderna, but I won't twist your arm or think you're wrong if you decide to get Pfizer instead, because some people are saying that might give you a little bit of jump. The other thing that I wanted to highlight that Mary said is that if you've had COVID, yes, you get some immunity, but we are out far enough that just like with the booster, we're not sure how much immunity you have, and that's why you should get the booster, and that's why you should get vaccine. Some studies show that you don't get that much of immunity and you can get reinfected, as Mary was talking about. Okay, the other thing that the question here, this is a really good one, is can a viral pathogen survive on a surface such as a chairlift? And at what point does weather play a role into sterilizing a viral or bacterial agent? I'm going to limit my answer to COVID because I haven't reviewed recently the data on the others, and there are so many bacterials, so many bacteria and so many viruses that I'm sure some, it is a risk. But again, my consultant and everything that I've been able to read, we have gone from washing our groceries and wondering whether we had to burn the blankets that you wrap patients in to thinking that the risk of that is absolutely negligible. And outside, that's why you're going to see that Vail has changed the recommendations, and I expect other resorts to follow suit, that we are just not as worried about it anymore unless you're a high risk. And we think that so the recording stopped and started, so I paused there. So anyway, I don't think you need to worry at all or lose any sleep, let's say, about getting COVID from being on a chairlift. The weather does play a role. Sun really helps. Cold weather really helps. The virus is not that hardy, even though the studies where they put it on things and find that it's still there hours later or even sometimes days later, the amount of virus that's left is not enough to give you the type of infection that we're worried about. It's just like a mask. Being outside is even better than a mask. And so if you're outside and you want to be safe on the lift and you're worried, just wear your mask on the lift. And many of you will have some type of protection for your eyes and often for your face. So with that said, Mary, again, I can't thank you enough for your lecture. And if anyone wants to unmute and ask any more questions, here's one. How about the CPR protocols? We're going to be going over that in pretty great detail during your upcoming practical. So I'm going to defer to that and defer to the fact that we're putting in our final thoughts on paper. But the protocols aren't going to be much different, except that, it's so nice that we don't have to worry as much because we'll be masked and we're vaccinated. What other questions they would have? Just unmute yourself and ask away. Well, with that said, we still have 56 people, so we didn't lose anybody. That's pretty good. Toph, if you're still there, do you have anything else that we need to address?
No, I think you pretty much covered it tonight. Yeah, thank you, Dr. Nguyen. Thank you, Mary.
Yeah, again,
thanks for having us.
The really good news are that vaccines have been shown without a doubt to work and also to be really safe. Oh, let me address one thing that is fairly new that I was reading about. I was telling Toph about it, if he hasn't already told you. A while back, there was a paper that came out, one of the articles that came out came out before it was reviewed, but it made the news like anything that could be negative about vaccines or masks made the news on those outlets that like to do that. And it said that young white males were more likely to get myocarditis by getting vaccinated. It was a true study that was done, but when it went to review, immediately the authors of that study withdrew their conclusion because they had used the wrong denominator to say that it happened. And what they found out that yes, there were some people who got vaccinated and got myocarditis, but it was at no greater rate than the rest of the public. It was a really good example of how misinformation can really make things look bad. So if any of you are worrying about that particular illness or disease or side effect from the vaccine, the actual authors withdrew their conclusions and apologized. So with that, which I consider really good news because I worried about that for some of you who fit that demographic, I think we'll say good night. And thanks again, Sue, and thanks again, Mary, and thanks again to all of you. And I sure look forward to seeing you. Now, one person needs to answer the question that I didn't have the answer to from Mary about how are things on the mountain as far as how it's looking. Toph?
Hey, Winnie, it's Chris Urkula. How are you?
Oh, hey, Chris, how you doing?
Hey, Greg.
Good. My question first.
Oh, good.
yeah.
Okay.
Okay, Mary, which patrol's better, Deer Valley or Park City?
I can't say. My old stomping grounds. I'm gonna have to say Deer Valley. You guys met Deer Valley, Oh my gosh. So don't kill me, too.
Oh,
Just because I worked at your Valley. Oh my gosh.
I figured that would be your
You
answer.
guys had to put
I
up
just
with
wanted to
me. Like,
set you up for
that's-
success there.
That's awesome.
Well,
Thanks
with
a
that,
lot, Chris.
with that, I think we will say the meeting is adjourned, and thanks again, Mary and Sue, and
All right. Thanks so much, you
Good
guys,
to-
for
good to
having
see
us.
all of
I
your-
appreciate it.
see all the things that you have on your little pictures, those of you who are brave enough to let us see you.
Oh, nice. I saw someone's cat. I love your cat. It's adorable. So,
Okay.
all right. Take care. All right. Bye-bye.
All right, see you later. Have a good
Bye-bye.
night.
Stop recording, Sue.
Yes, I will. Good night, everyone.
Night.